Hello and good morning, everyone. Hello and welcome, everyone, from Society for Health Research and Innovation. Welcome to the webinar series uh, conducted by Society of Health Research and Innovation. So, to welcome our speaker today, it's my privilege to introduce her. She's my trainer as well. Dr. Wathsala Hathagoda graduated from University of Kelaniya with second-class honors in 2011 and obtained an MD in pediatrics in 2019. She also received postgraduate general pediatrics and pediatric gastroenterology training, the John Redcliffe Hospital, Oxford University Hospitals, United Kingdom. Currently, Dr. Wathsala works as a honorary consultant pediatrician with special interest in gastroenterology at the Lady Ritchie Hospital for Children. And she's also a senior lecturer in the Faculty of Medicine, University of Colombo, Sri Lanka. Her research interests are pediatric inflammatory bowel disease and functional gastrointestinal disorder in children. Madam, over to you.
Thank you very much, Baba, for that kind introduction. Good morning to you all. So I know I can see a large number of participants despite this extreme weather condition. So thank you very much for joining in today. So my task is to talk about recognizing inflammatory disease in children. So that topic is something very closer to me. And I thought it's very important for me to increase the awareness among our colleagues as well with regard to this disease. So during next 45 minutes or so, I'll be talking about what is IBD and its incidence, as well as we would talk about few clinical presentations. Using the clinical presentations, I'll be talking about the clinical features as well as management. So let's start talking about what is IBD. Actually, the inflammatory bowel disease means there is a chronic inflammation in the gastrointestinal tract. So there are a lot of hypotheses put together to find out the exact reason. So the few reasons you can see in this slide. So the kind of established hypothesis is altered or immunodysregulation in the gut in genetically susceptible host due to altered environment. So in that case, you need to have increased exaggerated immune response. And also there has to be some genetic predisposition. You don't need, apart from that, there has to be some environmental changes, especially the things like infections, the medications, and the disuse of antibiotics, could be smoke, some of the health habits like smoking, stress, and also altered gut microbiota. So if you look at this slide, so it clearly shows. So in a non-IBD patient, if you look at the left side, you can see nice endothelium in the gut, as well as less number of cytokines and pathogenic cells, and having a nice gut epithelium, and also diversified microbiota. So having a lot of microbiomes which are favorable to our body. When you look at an IBD patient, you can see what has happened. So the gut microbiota has become very sparse. So the diversity has come down. So the possible hypothesis what they have postulated are due to hygienic theory and increased sanitation, as well as exposure to antibiotics from early life onwards. So that point is very important, because as clinicians, before you prescribe an antibiotic, you always need to think twice, is it really necessary or not? Because this is what is ultimately leading to a younger population. So if you are using too much antibiotics, so it can cause dysbiosis, or the pathogenic bacteria in the gut are kind of increasing in numbers than the common cells, and making the gut microbiota altered. And as a result, there is impaired epithelial barrier function and causing immune dysregulation. So this chronic inflammation causing leaky gut and then causing this malabsorption and other symptoms. If you look at your right, so you can see some of the causes which I described earlier as well are considered as environmental factors for this IBD pathogenesis, such as tobacco. They have said mode of delivery. If they birth using a cesarean section, so they are having high risk, and antibiotic exposure from early life onwards, dietary patterns, exercise, reduced exercise, geographical conditions, and urbanization. So, because the best example is among the migrant population to Western countries, so they have seen increased IBD in the second generation of that migrant population, especially people going from India, Pakistan, Sri Lanka to the Western countries. So their second generation are having increased IBD tendency. So they think that is because of mainly due to the change in the diet and urbanization. So this is the global increase of IBD. If you can see, the first case is during the Industrial Revolution, somewhere around 1859. And it took more than 100 years for the Western world to kind of get the number. But if you look at the new industrialized countries like, Australia, the Southeast Asian countries, so you can see the rapid increase of cases. So it took more than 100 years for them to peak, but here within 50 years, it has gone into a peak. So this incidence, this is not only for children, this is for overall IBD incidents, including adults. So you can see it's rapidly rising. So it's not explained by genetics, but what they say is it's due to environmental changes like westernization of the diet and change in the gut microbiota. So where are we now? So the estimated pediatric IBD incidence in Asia as well as Middle East varies from 0.5 to 11.4 of per 100,000 person year. So then we have to expect roughly 33 to 750, somewhere around that figure, new cases per year. So are we achieving? So when you look at our data this is from our clinic in the GI clinic at LRH. So over last nearly 10 years, this is what we have seen. So you can clearly see the increase in number of cases we diagnose every year. So it's somewhere around now for last 3 or 4 years, we have diagnosed somewhere around 25 new cases per year. So we all know, even in Sri Lanka, not only in adults, so even in children, the inflammatory bowel disease incidence is rising. So it's very important for all of us to know about this disease. So why we need to identify this disease early and why we need to treat this early? If you see the picture shown on your left, this is the natural progression of the disease. So initially what happens during this subclinical inflammation, so you might not see, if you miss to diagnose, then they will develop into strictures, fistulae, needing surgeries and colectomies. But if you are aware about the illness and if you try to diagnose them within this window, if you can do an early diagnosis, so you can see we can nicely control the disease without them developing complications like needing colectomies, needing any surgery. So that is why the important early identification is important. So what we know about IBD so far, so there are a lot of postulations. We don't know exactly what the cause. And the other thing is no curative treatment is available, but of course we can control the disease. And obviously, not only in the other countries, in Sri Lanka, the incidence is increasing dramatically. And if we diagnose early, so it will improve the outcome. So that is why we need to know about this disease well. So if we classify IBD, so basically we can classify into two types, Crohn's disease and ulcerative colitis. As you all know from your, medical school age, we know Crohn's means it can affect from mouth to anus. So anywhere in the colon or anywhere in the gut, so causing multiple skip lesions. As you can see, in ileocolonic involvement is more, but also they can have colonic involvement as well as upper GI involvement. But this area is the most commonest area which a child can have symptoms. Ulcerative colitis means it's continuous inflammation from the rectum up to the colon, up to the cecum. Sometimes you might see changes in the ileum due to the backwash ileitis, but basically it's confined to the colon. If you cannot classify it in between the two, because sometimes the histological classification is sometimes if it is very early disease, then you cannot tell exactly whether this is Crohn's or ulcerative colitis. So in that instance, we name it as IBD unclassified. So sometimes later in the disease, so you might be able to classify it under Crohn's or ulcerative colitis. So that is why we have a third classification as IBD. When you look at the clinical presentation, so of course we know that it is a problem with the gastrointestinal tract. But strangely, there are a lot of extraintestinal manifestations we should know and we should be aware of. And that is the main reason why in children, sometimes we miss to diagnose IBD early because the presentation can be very vague. So the GI manifestations we all are well aware of: abdominal pain, weight loss, bloody diarrhea, could be nocturnal diarrhea, can have perianal involvement like recurrent abscesses, fistulae. So those are the GI manifestations you would observe. Whereas the extraintestinal manifestations are among them the growth retardation and delayed, puberty is one of the commonest, I would say. And also they can present with skin manifestations like erythema nodosum, pyoderma, and they can have peripheral arthritis, sometimes uveitis. So because of these extraintestinal features, sometimes clinicians miss to diagnose IBD. So I thought of presenting few clinical histories, and then we can discuss the clinical presentations and the consequences. So the first case I'm going to discuss. So we received a 12-year-old previously healthy child. So she was from, I think, Kulia. So the history was with bloody diarrhea, and she was having perectal bleeding for a duration of 2 months. And she was also having abdominal pain, intermittent vomiting, and tinnitus. So she was initially treated as possible dysentery with several courses of antibiotics, but her features were continuing. And then she also had loss of appetite and lost 5 kilograms over a period of 2 months. And then she was referred to LRH. However, other than these GI symptoms and constitutional symptoms, she didn't have any extraintestinal manifestations. So when we examine her, as you can see, her height, which was on the 3rd percentile, and weight obviously on the 10th, and the BMI also on the 25th. And the examination we did not see any peripheral general changes other than some asymptomatic anal sacs in her around the anus. So when we did the bloods, they were not that, I mean, they were unremarkable. As you can see, the hemoglobin was 11.5 and the platelet was normal and inflammatory markers all negative. Even the albumin was 3.7. However, considering her weight loss of 5 kilograms over a period of 2 months and also persistent GI symptoms, we did the ileocolonoscopy, upper GI endoscopy, and colonoscopy with ileal intubation. So during the colonoscopy, what we observed, multiple abscess ulcerations. It was extending from ileum to the sigmoid colon. And when we look at the histology, uh, it showed acute and chronic colitis with evidence of granuloma. So the histology itself uh, was in favor of Crohn's disease. And then we started the treatment. So when we talk about management of inflammatory bowel disease, so it's very important to heal the lesion. So that means we again we use the same terminology as nephrotic syndrome. So we try to achieve remission. So for that, the best treatment would be prednisolone. So in severe, if you can see this photograph, it's severe sort of involvement of the colon and the ileum. So then we thought if we give oral medicines, it will not absorb. So then we started with IV preparation. So we gave it for nearly 5 to 7 days. And then later on changed to oral prednisolone. But again, that is for short period. So prednisolone therapy, we have to tail off within 3 months and we have to stop. And in the meantime, we need to introduce a maintenance agent. So usually we go for azathioprine as the maintenance. While you are tailing off prednisolone, it's always need to put them on a maintenance medication for immunomodulatory medication to suppress the immunity and then to control the disease. And always nutritional rehabilitation should go hand in hand because this child has lost quite a quite large amount of body mass during that period. So it's always need to do intense nutrition rehabilitation. So you might be thinking, okay, do we have exclusive enteral nutrition available in Sri Lanka? So that is an elemental formula. The formula they have broken down into amino acid levels, and then it can be used as a treatment. Not only it will heal the mucosal epithelium, but also it will improve the nutrition. But unfortunately, Sri Lanka, we don't have the this formula preparations. So therefore, we have to rely on steroids as for the induction therapy. So what are the things we can learn from this case? So sometimes, as I told you before, growth failure is often the earliest sign. If you can remember the case scenario, the bloods were all normal, so they were within the normal range. However, she had poor weight gain and she had poor height velocity. If you can remember, the height centile was in the lower margin. And sometimes you might see delayed puberty. So they can be the only presenting features in Crohn's disease. So always you need to think if a child is coming with growth impairment or pubertal delays, you need to always think about a chronic illness. And also the combination of these GI symptoms, these colitis symptoms, the having blood, bleeding per rectum, and the growth, plus the perianal manifestations, the perianal tags, then always you need to suspect inflammatory bowel disease. So if you have any questions, you can kind of ask at the, if you have any burning questions, you can ask, but otherwise I would entertain all the questions at the end of this lecture. So I'm moving to, so the first case is quite typical. So we know if they come with blood and mucus stool, having vomiting, abdominal pain, having tenesmus, weight loss, then obviously that is the textbook presentation of IBD. Now I'm going to talk about the atypical presentation. So this baby, 8-month-old, I think this baby was transferred from Nigambo with a short history of loose stools for 1 week, associated with lateral lower limb edema. So child was having actually, it was pedal edema, never had periorbital low abdominal edema. It was It was only the fetal edema. And this baby was having watery stools, have very short period of time, 1 week, without any blood or mucus. And this is what happened. So actually, this child was in the LRH for nearly 2 months. So as you can see, there's a rapid drop in the weight, but the weight has been very well up until this point. Before the illness, child has been very well without any issues. And with this acute diarrhea and swelling, there was a rapid loss. And as you can see, you can't appreciate any generalized swelling. So it was only in the lower limbs. And when you look at the bloods, you can see her hemoglobin was 7.5, which is quite low. And platelet has gone up to 718, and ESR was 55, CRP normal, and having low albumin of 21. So we did the urine PCR, urinary protein excretion, which was negative, and the liver profile, which was completely normal. So we thought, okay, this child having protein losing enteropathy, must be losing all proteins from the gut because of this acute illness, and then decided to do the ileocolonoscopy. So we did the colonoscopy. It was macroscopically normal. So I did the upper GI as well as colonoscopy with ileal intubation. So macroscopically, I thought, okay, it's a normal colon. However, when we look at the histology, so it had this cryptitis, crypt distortion, and some crypt abscesses suggestive of Crohn's disease. So then we started on treatment again with methylprednisolone because of this edema. We suspected baby must be having gut edema as well. And then, despite 2 weeks of methylprednisolone, child still didn't respond. So we had to start on infliximab. So that is a biologic treatment we use to suppress the inflammatory marker. So then, if you can remember the inflammation happening at the gut, so TNF, tumor necrosis factor, is one of the inflammatory marker which is responsible for this inflammatory bowel disease. So infliximab blocks this TNF alpha. So we started infliximab early together with albumin transfusions and high protein diet and nutrition rehabilitation. And then we were able to manage the disease. And actually, a few days, I think 2 or 3 days back, child went home with treatment. So what I wanted to highlight was IBD can also present in infancy. So we have nearly 20 children who have presented less than 2. So we call that entity very early onset. So if they are having symptoms before 6 years, so they will be called as very early onset IBD. So that is also not very rare. So if the symptoms are of because of obviously you know that this child had protein losing enteropathy, so that sort of a situation you can't think, okay, this is just an infection. So if you think possibility of protein losing enteropathy, so which also can be a manifestation of Crohn's disease. I'm not telling it's the only reason, but it can be. And also normal NP does not exclude IBD. So that is one of the biggest mistakes we see among surgeons, because as you all aware, we don't have pediatric gastroenterology as a subspecialty in the country yet. So because of that, most of the time we rely on surgeons or adult gastroenterologists or surgeons to do these endoscopies. So sometimes thinking, okay, the mucosa is normal, so sometimes they don't take biopsies. So that is the other problem. Even though the macroscopic appearance is normal, you cannot exclude, IBD, because the disease can be in the early stage. Take some time for you to give some macroscopic changes, so then you might see the histology changes. So it's always important to get biopsies, although the macroscopy is normal. And it's always important to check the albumin growth in a child who is having persistent diarrhea. And also early suspicion, early treatment can avoid complications, especially in this child, because the growth is very important, development is very important. So identifying a chronic disease early is very important for these children. So a third child is again an adolescent boy, 14-year-old. So I think he was managed at Fatupitiwala. So he first admitted 3 months back. He was perfectly well, admitted 3 months back to Vatupitiwala with fever, and he was having some headaches and managed as meningitis, needing antibiotics for 12 days. And after discharging, he was having continued fever, intermittent fever, watery diarrhea, also with weight loss. 6 kilograms over a 4 month he has lost. However, he never had rectal bleeding, no abdominal pain, and he never had any extraintestinal manifestations. Actually, this child was referred to me by Pardenia sir. So they have met Pardenia sir and then sent to us. And when you look at him, so I was amazed. He was very thin, as you can see, hardly any muscle mass. And although his height was on the 25th centile, his weight was less than 5th, and also his BMI. We did his bloods. They were unremarkable, except you can see the platelets were a little bit in the higher side, 516, and his ESR was high. So we did the upper GI endoscopy and ileocolonoscopy. So you can see, so I have a video here. So this is what we saw. So he was having extensive involvement of his colon. You can see this snail track sign and pancolitis. So this was from the rectum to the ileum. It was fully involved. So when we look at his histology, so he was having giant cells as well as granuloma everywhere. Even this is the stomach histology. So you can see a giant granuloma here, non-case eating granuloma here, and also a giant cell. So we kind of started managing him as a Crohn's disease and started on methylprednisolone together with nutritional intervention. And still he's in the ward receiving treatment. So I have a feeling that he might need early biologic therapy because he was having extensive involvement of the gut. And also we need to be cautious about his puberty. He's still 14 years and pre-puberty. And so then we have to intensify our management to prevent the consequences of the disease. So again, what are the take-home messages? So having bloody stools is not essential. So especially Crohn's disease. So you can have just watery stool without blood. And always you have to think about the weight loss. So if a patient having a significant unexplained weight loss, you always need to have a high suspicion. And it's always essential to kind of perform endoscopy and then to get the biopsies to kind of come to the conclusion. And then early treatment is the key factor, because these children, if they have recurrent inflammation of the gut, so they can have strictures and more prone to get colonic carcinomas in the later life, because these are young children, so they have a long way to go. We don't have any curative treatment. It's only the therapeutic management we have. So then we have to minimize the disease progression. So it's very important to start treatment early. So another case, again, a 13-year-old boy, he was referred to us by, I think, Chayatri madam from the rheumatology clinic, because he was having bilateral knee joint arthritis and sacroiliitis, and she has started disease modifying agents, but he was not responding. He never had any GI symptoms, but also had some loss of appetite and lost 2 kilograms of weight. Although he didn't have any, GI symptoms, we always need to think of extraintestinal manifestations. So when we did the investigations, he was having high inflammatory markers, including ESR. So therefore, we did the colonoscopy, then found to have active colitis suggestive of ulcerative colitis. So then we started him on medications, disease-modifying medications, but he was again kind of had relapses with sacroiliitis. So then we had to start him on biologic treatment. So again, what I wanted to highlight was extraintestinal manifestations can precede GI symptoms in pediatric IBD. So you do not need to have GI symptoms all the time. So they can present with something like uveitis, they can present with perianal disease, they can present with skin lesions, and later on, sometimes you might see the GI symptoms. So out of the extraintestinal manifestations, arthritis is one of the most common features and could be the first clue of IBD. So it's always important to think when a child is presenting with, arthritis, peripheral arthritis, if they are not responding to the conventional treatment, so it's always need to think about the other possibilities. One possibility is, can this be a IBD? So these are other presentations. Now I get a lot of referrals from the surgical wards because what our practice is, when if they have perianal abscesses or fistulae, so they are being managed as surgeons. Now, because of the improved awareness, when they are getting multiple abscesses, so we do get referrals from the surgeon. So then, as you can see, these are two patients with Crohn's disease. So luckily referred to us, and we have started treatment. As you can see a perianal tag and multiple perianal abscesses needing INT. And again, this child had multiple fistulae, as you can see. These are the pus draining fistulae. So never had any GI symptom. So one child had growth failure, but other one never had growth failures as well. And when we did the colonoscopy, rest of the colon was normal. However, when we took the biopsy, so biopsy shown some granuloma in this fistula tract. So always, if they are having perianal disease, could be multiple perianal abscesses, recurrent perianal abscesses, could be recurrent perianal fistulae. Again, it could be the presentation of IBD. And again, we got a child from Putlam having some multiple perianal tags. Unfortunately, I don't have the photograph. And that child was referred to the STD clinic. Actually, they were suspecting suspecting a STD lesion, and actually ultimately ended up as having Crohn's disease. So then always you have to think about this when you see this kind of perianal lesions, you have to think about Crohn's as well. And this is a kind of growth chart of a small baby presented around 4 months. As you can see, the growth, it has flattened. Still, it has not, he has not achieved remission, as well as the height. So growth itself can tell us, okay, something is abnormal. So always need to think about the possibility of very early onset Crohn's cell. And this is an older child, as you can see. Even though he didn't have much of GI symptoms, he was emaciated, having loss of weight, loss of appetite, and a lot of skin lesions, suggestive of pyodoma. So then we kind of concluded that he was having IBD. So those are some of the presentations we always need to think of IBD. And this again, another child, he was short and also having some scoliosis, as you can see here. And when you carefully look, so he was having wedge fractures here. So this child was managed from Gaul, managed by in the peripheral hospital, because he didn't have much of GI symptoms. So the main complaint he was having was abdominal pain, and sometimes time to time he was vomiting and loss of appetite. So he didn't have any diarrhea, he didn't have PR bleeding, so no one thought of doing any endoscopies. He was treated as gastritis and gastroenteritis, given some omeprazoles for a long time. And ultimately, when he came to us, so we did the bloods and then we did the endoscopy. It was Crohn's, and as you can see, he got this wedge fracture not due to steroids, because of the disease itself. So, because long-standing untreated Crohn's disease can cause nutritional impairment. So as a result, he got this wedge fracture. So, and short stature. So when you see short stature, if you compare with the parental height, so if you see it's less than the mid-parental height, then always need to think about underlying chronic illnesses. So one thing is inflammatory bowel disease. So that is why we need to start advanced therapy as the first line. So again, if I kind of re-emphasize this slide, so the natural progression, so the disease initiation and you have subclinical inflammation, and then early disease, you will have strictures, fistulae, and the late disease, you need surgeries, bowel resections, colectomies. So if you do the diagnosis early and if you can start advanced therapy early, so you can see nicely, so we can control the disease without needing much surgeries and without them getting much complications in later life. So it's very important to start kind of advanced therapy early rather than later in the disease. To do so, we have to be vigilant and we should be able to identify and refer these patients early for the diagnostic purposes. So before, rather than you starting the therapy here, so if you can start the advanced therapy before the damage occurs, before the strictures, then they can have a relative smooth life without needing much interventions. So this is about a bit about the medications we use. So I already told you steroids is the mainstay we use for the remission induction. So when they are having active disease, so we start with steroids, could be intravenous steroids, could be oral steroids, and to get then we once we start with steroids, we need to do it with an immunomodulator to maintain the disease remission. And then you can go for your biologic therapy, that is TNF inhibitors, tumor necrosis factor inhibitors, things like infliximab, adalimumab. And also we have JAK inhibitors. We only have tofacitinib in the country and the other biologics. Unfortunately, we don't have anything available. So this is the treatment ladder. So what they recommend is, if you think the disease is aggressive, so you can start with the aggressive therapy just to minimize the complications. So that is what I have to kind of tell in my lecture. So just to summarize what I talked today. So inflammatory bowel disease, of course, incidence is rising in the whole world, but in Sri Lanka among children, So we do see a rise in inflammatory bowel disease. So it's very important as clinicians to be aware about the disease and know when to refer for the specialized management. And the other important thing I want to highlight, growth failure may be the only presenting feature. So it's always important to look at their growth trajectory. So looking at the growth chart, plotting the height centiles and the weight, and looking at the trajectory is very important. So if you see growth failure, so you have to investigate why. And the other thing is they don't present the GI manifestation always. So there are extraintestinal manifestations which are common, including arthritis, skin lesions, and uveitis. And the other important point I wanted to highlight was perianal disease. So when you see a child with recurrent perianal symptoms, could be fistulae, could be abscesses, then you always need to keep an eye. This could end up as Crohn's disease. And for all the clinicians, early referral and diagnosis, it improves the outcome. If you can remember what's a natural progression. So it's our duty to think and, be vigilant about IBD. And if we can start advanced therapy early, so it can prevent the irreversible bowel damage. So if you have any questions, so I'm ready to answer your question.
Thank you, madam, for that enlightening talk. And it was really thought-provoking and empowering the early diagnosis of IBD in children. And we have some exciting questions in the chat box, madam, so we can discuss one by one. Can you hear me, madam?
Yes, Baba, yes.
Okay. So the first question is regarding the inflammatory markers. So they have asked like, can we use stool calprotectin and electroferrin as screening tool? How sensitive is, and also what is the incidence of false positivity and negativity?
Yes, thank you very much for asking that question. I wanted to wanted to talk about this calprotectin and lactoferrin. So they are one of the best screening tools in inflammatory bowel disease. If we talk about calprotectin, if it is about 250 micrograms per liter, so then that is highly suggestive of inflammatory bowel disease. But the problem we have in Sri Lanka is we don't quantify calprotectin. In our labs, they don't quantify it. What they say is whether it's positive or negative. The problem with that, calprotectin is an acute phase protein. It's a neutrophil, released from the gut epithelium. So in any inflammation, any infection, any allergic condition, you will see high amount of calprotectin. So it's not specific to IBD. Because of that reason, in Sri Lanka, if they say calprotectin is positive, so you don't know. It could be due to IBD, it could be due to something else. So it's good as a screening if we can quantify. But otherwise, in Sri Lanka, having a positive calprotectin, it's going to be any help by doing it because it's expensive as well. So that is why usually in our regular practice, we don't do it due to that reason. So you can see in any of our patients, we have not done it simply because we cannot quantify the number. So without knowing the number, we don't know what it is. I think I answer your question. But for diagnosed patients with IBD, that is a very good screening tool. So if we can quantify, so we can do the calprotectin levels, and then we can tail off the management. So that is what they do in the other countries, but we don't have that facility here.
Thank you, madam. The other question is how to differentiate IBD from celiac disease?
Yes. So they have some, some features, the celiac again can have growth problems. Celiac again can have, some children can present with diarrhea, anemia, abdominal distension. So the diagnosis of celiac is very clear. So if we can do the antibodies, tissue transglutaminase antibodies, if they are more than 10 times with positive EMA, endomysial antibodies, we don't need any tissue diagnose, you can straight away diagnose celiac. But the problem comes with the cost, because they are very expensive, some around 25,000. Then what you can do is you can do the biopsy of the duodenum. So we look at the duodenum villus. So in celiac, they will see lymphocyte infiltration and duodenal villus atrophy. So we are seeing those features. However, in celiac, you won't expect them to have any other changes in the colon. So basically, the small bowel, they will have the specific histological changes. So although the clinical features are somewhat similar, but the diagnosis, the test will give you different results. So then you can differentiate the two.
The other question is, in the case one, Madam has discussed, can intestinal TB be a possibility?
Yes. So strangely, in Sri Lanka, we have yet to see an intestinal TB patient. And so we always, when we see granuloma, our histopathologists always look for that possibility as well. And as a routine test, before starting biologics, we do check the, the TB exposure with MAN2 and the chest X-ray and other investigations. Of course, when you see a granuloma, it could be tuberculosis, it could be sarcoidosis, it could be a malignancy. Those are possibilities. But there are things we can do to exclude.
The other question is, Madam, how sensitive ESR in IBD? Any best screening test for GPs? What are the inflammatory markers are useful in screening for inflammatory bowel disease?
Yes. So if we talk about inflammatory markers, as I told you before, they can be normal. But the best, I would say, the full blood count will show either mixed deficiency or iron deficiency anemia. And for Crohn's, they will have reactive thrombocytosis. So always I look at the platelet count, I look at the hemoglobin in a full blood count. And also I would like to request CRP. I would say it's better than ESR. No point of doing the both. Either you can do a CRP or ESR. Because of the time constraint, I think CRP would be enough. And to get an idea about the protein losing, the malabsorption, then I would do an albumin level. And also sometimes they can have liver involvement, things like sclerosing cholangitis. So ALT is another marker I would recommend. But again, growth, I would say, is one of the best clinical indicators we can all rely on, because sometimes these investigations can be all normal.
The other question is there any specific position of fissure in anal area to suspect IBD?
Actually, there's no such specific position in IBD. So there can be they can be anywhere in the around the anus, and could be sometimes it won't open to the mucous, cutaneous. There can be colonic fistulae. There can be fistula from the colon to the bladder. There can be fistula inside the colon and the ileum. So there are no such thing. By looking at the fistulae, we can't say whether this is due to IBD or.
Okay. The other question, Madam, what should be the approach to prevent osteoporosis in IBD?
Yes. So it's actually the osteoporosis, vitamin D deficiency is multifactorial. One thing is disease itself. It will affect the absorption of calcium and vitamin D from the ileum. And the active inflammatory or cytokines will reduce the appetite. So then anyway, they are not taking enough. And due to anemia and lethargy, their physical activities are less. And then they are having ongoing diarrhea. Again, they can lose proteins and the vitamins. So there are a lot of factors. So to prevent osteoporosis, so it's always what we do now as a practice, we arrange a DEXA scan. So for the the third boy, the 14-year-old with the very thin boy, so we again arrange. So it's very important to see how the bone mineral density, and from that point onwards, we can optimize vitamin D, calcium. And we have actually 3 patients whom we have started solandronate, the one with the wedge fracture. So then we can start vigorous treatment, because as you all know, if you don't treat, then they can end up as shock. So there's a tendency of them to be short in the adult life. So we have to prevent it early. So my recommendation is screening, so arranging DEXA and starting therapeutics early, and then continuation of those vitamins is important to prevent osteoporosis. And also once they gain enough muscle mass, we have to encourage them on physical activities, and then having a healthy diet. So everything is important.
And some more questions, madam. There are 3 more, I think. How about doing ANA levels in IBD?
There's no,
Yeah.
sorry, yes, ANA, unless you suspect something else, so you won't find anything by doing ANA if it is IBD. So there's no connection. But there are some other auto-inflammatory conditions, like things like this HLA-B27. So they have some auto-inflammatory conditions where you can have positive ANAs, but IBD itself, there's no place.
Okay. The other question is, how common spondylitis in IBD?
Spondylitis, I won't say very common, but it's a mode of it's a type of extraintestinal manifestation. So spondylitis, sacroiliitis, or peripheral arthritis is a presentation. So I don't say it's very common, but uh, children can present with those features.
And the last question, I think madam has already answered anyway. Why high platelet levels in IBD?
Yeah, so that is due to the ongoing inflammation. So if you can remember the amount of cytokines and amount of inflammation happening inside the gut. So as a result to that inflammation, so especially in Crohn's, not in ulcerative colitis, because it's basically a submucosal lesion. So we do see high platelets due to ongoing chronic inflammation.
Okay.
Just to answer to the previous question, Baba, about the ANA, actually, we got few children initially. So IBD is very difficult to diagnose sometimes, because we got actually 2 children initially managed as SLE, because they can present with various multisystemic involvement, and ultimately ended up as IBD. So that time I thought, anyway, in a normal population, there's some certain proportion, some around 10 to 15% can have positive ANAs. So that may be the reason why they were kind of directing their investigations toward SLE, but actually ended up having IBD. But there's no clear correlation between positive ANA and IBD. So we don't do it as a test. But when you see a child with growth failures, SLE is one of the differentials. So that may be the reason why that question was made, but there's no clear indication to do anything.
And one last question on treatment, madam. How long we have to continue the treatment? Is the treatment is lifelong?
Yes. So as I told you, it's a chronic inflammation. So there's no curative methods available. But of course, we can come down to monotherapy. So we don't need to give everything which it's so due to the cost itself. I try for 1 year and then we do repeat the endoscopy and see the activity in the histology, and when we decide to kind of stop giving infliximab and then to put them on oral, usually the treatment is lifelong.
So thank you very much, madam. Thank you very much for sharing your expertise with us, and it was a thought-provoking lecture. And thank you for the participants who are joined today and participate actively with a lot of good enlightening questions. So thank you very much again, and hope you have a good day, and hope you all are safe.